We are chairing a session entitled Cardiac Contractility Modulation, Current and Future Clinical Applications. This is a mini symposium supported by a grant by Impulse Dynamics. And we have three presentations. One, and I would like to introduce Professor Hasenfuss from Göttingen, addressing unmet clinical needs in heart failure. He is an expert in the area of heart failure, and he's going to discuss this problem. Thank you very much.
Thank you very much, Martin, Dr. Riccio. Ladies and gentlemen, it's a great pleasure for me to give this introduction. Now, as you all know, treatment of heart failure has improved tremendously over the last decades, but still there are a great number of unmet needs that need to be addressed, and this is where cardiac contractility modulation jumps in. My disclosure. The improvement includes new drugs over the decades, which are listed here, which you all know, so I don't have to address the details, and of course the devices, the ICDs and the resynchronization therapy. But despite these advances, increasing numbers of patients suffer from high rates of hospitalizations, poor quality of life, and high risk of death, and this is partially due to the improvement of the treatment of patients with myocardial infarction. Survival, at least for those who come to the hospital, has increased significantly, and many of those will end up with heart failure. And this is a slide showing overall survival over the decades, and it's rather depressing to see that at least from 1987 to 2001, although there was a small improvement, there was not really what we would like to see, a tremendous shift in this survival curve, despite these new treatment approaches we were addressing. Now, cardiac resynchronization therapy improved the situation in patients with heart failure. It's applicable to patients with reduced ejection fraction, those who have dysynchrony of myocardial contraction, and it's currently the most successful and widely used device-based therapy for treatment of heart failure. This shows data from the CARE-HF trial, including patients with New York Heart Association functional class 2, 3, and 4 with an ejection fraction below 35% and a QRS of above 120 milliseconds. And you see the mortality curves, and what is important to realize that with best medical therapy, 1-year mortality is 11%. And up to 1 year, there is no difference between the treatments, and the mortality benefit of CRT becomes evident after 1 year. And with respect to heart failure hospitalization, this is the figure from this study. There is a 7% reduction in heart failure hospitalization with CRT at 1 year. This is significant, but it's not so much. Analysis from a Miracle trial showed that with all parameters evaluated, the total group of CRT-treated patients versus placebo had a benefit in 6-minute walk, in heart failure questionnaire, and in peak VO2, and also with respect to New York Heart Association functional class, but the responder rate is not 100%, and from this analysis, the responder rate was calculated to be about 50% only. Now, the critical question is, why is the responder rate of CRT not 100%, and rather only half of group of patients treated with the device are responders. There is new data which clearly indicate that this is due to implantation of the device in patients with a QRS below 150 milliseconds. This is from MADIT CRT. And the effect you see in the combined endpoint of survival and heart failure development is driven by the reduction of heart failure events, and the effects are best in patients with a QRS above 120 milliseconds. And just a few weeks ago, this meta-analysis was published in Archives of Internal Medicine, which includes 5 trials: Companion, Carriage F, Reverse, MADIT, CRT, and Draft. They study the effects of resynchronization therapy on the composite endpoint of death and hospitalization. And this shows you the group of patients from the various trials with a QRS of at least 150 milliseconds. And as you can see, there was a benefit, a significant benefit in all these trials on the composite endpoint. When the QRS was below 150 milliseconds, there was no benefit, not in an individual trial and not in this meta-analysis. And this is a meta-regression analysis of the effects on CRT on this combined endpoint, showing that there is an inverse relationship between QRS duration and a positive relationship between QRS duration and the benefit you have with this treatment therapy. And this also is very interesting, sensitivity analysis. And this shows that what I said before holds true for patients with severe heart failure, New York Heart Association class 3 and 4, but also 1 and 2. The benefit only shows up with the QRS above 150 milliseconds. That holds true if an ICD background is there or not. Obviously, it's generally applicable. So to summarize this, also medical therapies have improved survival in patients with reduced ejection fraction. Mortality and morbidity remain high. CRTD improves quality of life, hospitalization, and mortality in patients with a low ejection fraction and in patients with a wide QRS complex above 150 milliseconds. And CRT can slow progression also in patients with mild heart failure. Again, if the QRS is above 150 milliseconds, and approximately 40% of CRT implantations have been done in patients with a QRS of 150 milliseconds. And this explains the low responder rate, because for patients with normal QRS, no device-based therapy is available to treat symptoms of congestive heart failure. This is where cardiac contractility modulation comes in and was developed. And briefly to show you what the device is doing, you see the EKG, and the impulse comes shortly after the R wave with 5 impulses with an amplitude of 7.5 volts. This is sub-threshold, so you don't get any after depolarization, but many experimental studies show that with this type of stimulation, you normalize altered protein phosphorylation, gene expression, protein expression, and contractile performance of the myocardium. This is how the device looks like. You have an electrode in the atrium and 2 in the septum. The device stimulates over 7 hours per day and needs recharging after 1 week with this device, which is put on the skin. So this symposium will cover in the following presentations the mechanisms by which cardiac contractility modulation impacts myocardial performance, review the results of randomized trials, and give an overview of ongoing prospective multi-center study. Thank you very much for your attention.